Sir, these are the CT. So these are the MIP images, and I can see there is a circumferential hyperdense area around the aorta, and aortic lumen, it is irregular. And
so what happens to it here? Where are we now? Let me just stop for a second. I will start from the beginning. So we're just working our way from the top. I'm going through the aorta, down, down. Focus on the aorta, forget everything else. Down. Okay, so what's going on?
Sir, there is, this is aortic aneurysm.
Okay, just focus on the aorta. So as we go down, what's happened to the aorta? Where happened to the vessels? Where are they?
So there is no specification of the aorta with the contrast, and vessels, they are also not specified.
Okay. So the aorta divides into what? When the aorta bifurcates, what are those vessels?
So common iliac vessels.
Okay. So you see one common iliac artery here, and you see another one here. What's wrong with them? They are?
So they are not, so there is no contrast within them.
What does that mean then? If there's no contrast within them, then they are what?
So it means thrombosed.
Okay, yes, so they are occluded is the term to use.
Occluded.
So they are occluded. Okay, right, all right. I'll go through this with you. So number one, this is not an aneurysm. This is and again, this comes back to looking at enough of these. So if you look at enough of these, you will know that this is a normal caliber of the abdominal aorta. And if you don't believe me, you can measure it. But this is what the normal abdominal aorta looks like. You can see diffuse atherosclerotic disease. So as we go down, the lumen of the aorta, which should be like this, is now reduced to something like this. And eventually, as we go down, both common iliac arteries are occluded. You don't see them at all. They're still occluded. Yes. And then you see, what artery is this? Just at the femoral head, what artery is this? What artery is this? Coming into anatomy again. Forget the... Common femoral. So the common femoral arteries are patent, but the external and common iliac arteries are occluded. So this is an occlusion of both common and external iliac arteries. And the common femoral artery is reconstituted by, you can see these inferior epigastrics and circumflex iliacs. These then reconstitute the common iliac arteries. So what I wanted to show you is this is again aortoiliac occlusive disease. So again, anatomy is very important. Knowing your arterial anatomy is very, very important. So this is an atherosclerotic occluded distal aorta and common iliac arteries. This is not an aneurysm. Okay. Excellent. And here's some reconstructive imaging here. You can see that the aorta kind of stops here. You don't see any common iliac arteries here, but you can see these huge collaterals that reconstitute the common femoral arteries here on these images. So this is an infrarenal aortic occlusion, and bilateral common and external iliac arteries are occluded. So again, coming back to what I said in the original slide, what is this study? So this is a CT angiogram, and this was done for obviously distal peripheral vascular disease. Leriche syndrome could have been one of them because both the internal iliac arteries are also occluded. So it's to determine what the anatomy is, what the study is, knowing the branches of the aorta, knowing what the normal diameter or the normal aorta looks like to differentiate from an aneurysm. And when you don't see contrast on an arterial phase study in an artery, it is occluded. I want you to use the word occlusion rather than thrombus. Okay, just a brief spiel on CT angiograms. I'm just going to go through this really, really fast. I'm going to ignore this. So CT angiogram for the lower limb, why do we do it? We do it to help in planning what kind of treatment the patient should have. And we tend to use the task classification of treatment. So basically A to D. A is a simple stenosis, and then going to B, which multifocal stenosis, short occlusions, long occlusions. So the more complex lesion, the less likely and the more likely that the patient should have surgery rather than endovascular treatment. However, this is not something that you would be expected to know the task classification for an exam. I'm just telling you why these CT scans done and how do we interpret them. So when you are looking at a CT angiogram, you do not have to mention every single stenosis or occlusion. Just do it by region. Say there are multifocal stenosis or occlusions. So do specify whether the disease is focal, diffuse, or multifocal. Do measure the length of the disease segment. So if it's a long segment occlusion of the SFA, do measure it. Coming to the aortoiliac segments, compare one side with the other. Talk about calcification. If there's an aneurysm, mention it. And the occlusions, where are the site of the occlusion? Where is the occlusion? So like the last patient had an infrarenal aortic occlusion and the common and external iliac arteries were occluded. And stenosis, the extent of the stenosis is important. When you go below the inguinal ligaments, look at each leg separately. Look at the right and the left leg. If you're given the site, so let's say that the patient has left lower limb critical limb ischemia, then assume that the right is normal. So again, the artery is either patent or it's occluded or it has a stenosis. That's all it is. If it's patent, there's contrast in it. If there's no contrast in it, it's occluded. And if there's partial contrast, then it's stenosis. That's all you need to know. This is a template. This is my reporting template for CT runoffs. So this is a normal study. So this is kind of almost like a checklist to look at. What is the caliber of the infrarenal abdominal aorta? So is it aneurysmal or not? I have a look at the major branches and the origins of the celiac axis, SMA, IMA, and the renal arteries. Have a look at the abdominal aorta and the iliac arteries and see whether there is significant atheromatous disease or not. And here I've said that they're free of significant atheromatous disease. So use this almost like like you would look at a plain chest X-ray and you have some kind of a template. You can use this as a template for looking at CT angiograms. And then the lower limb. So if the vessels are patent, so patent common femoral, SFA, popliteal profundifemoral artery, popliteal artery, and tibioperoneal trunk. And are these vessels patent? So are the vessels patent? And if they're not patent, are they occluded? That means no contrast, or they're stenosed.
So these are axial images of abdomen showing arterial phase.
So CT abdomen arterial phase. Okay, good. And focus on the vascular findings only. So I'm going to show you a couple of images. And let's just stick with this one. Tell me about this image.
Sir, on the given images, there appears to be asymmetrical thickening of the abdominal aorta, which is not significantly causing the narrowing of the aorta. Few atherosclerotic plaques are also seen. Also, there appears to be an enhancing lesion in the lateral abdominal wall, which has same density to that of the aortic contrast. In the lateral right lateral abdominal wall. And sir, I'm not sure. I would like to review the rest of the images to see what it is.
All right.
It might be calcification, but its density is equal to that of the contrast.
Okay.
And
so
also I would like to review the plain images to confirm.
Okay.
And in the given images,
on each slice, slow down. On each slice, I want you to look at the aorta and that finding. So as I'm going down, you've seen this image, focus on the aorta and that finding in the right lateral abdominal wall. So look at the aorta, look at that, whatever it is. What's going on here? So what's happened to tell me about the aorta.
Yes, sir. in the given lower images, the lumen of the aorta appears to be getting narrowed and no contrast to pacification in the bifurcations. Common iliac bifurcations are noted, and there appears to be some stenting in it.
Okay. Excellent.
Or it might.
Okay.
Yes, sir. So I would correlate with the history of any previous intravascular procedure.
Well, the patients had stents, right? So the stents are blocked. Yes.
Right, sir.
Okay.
Yeah, there's no.
You could you know, if you called it stent, and if it's calcification, or if it's calcification versus stent, it's not important. These are occluded. The common iliac arteries are occluded bilaterally. Okay. Yes. Next slide. So you're right. There's a stent here. So there's a stent here. You can see the external iliac artery. So do you know what this is then? Given the, what do you think this is?
So these might be the collateral development.
Oh, that's a very, very big collateral. Okay, I'm going to go down one more slice. Okay, so this this tube ended up into joining something like this and something like this. So do you know what this is? What have I shown you?
No, sir, I haven't seen it before. I think this is also specified with the contrast, and it has some intravascular connection, but I'm not sure what that stent is or that.
Oh, okay, all right. You did very well to pick this up. A lot of people would have ignored that and just carried on with the film. So you may not have seen this before, but you can see that this tube comes from the top, and then it divides and it gives blood supply to both lower limbs. So you can see this appearance. So I want you to focus on this appearance. So this is a PTFE graft. So this is a bypass graft, and this is its typical appearance on a CT scan. All right. So this is something that somebody has surgically placed, and this is an axillo-bifemoral bypass graft. You can see the abdominal aorta, and you can see the heavily calcified. I mean, these are volume rendered images, so you can't really comment on the opacification of the arteries. But we know that the common iliac arteries are occluded. So how is the blood getting to the leg? You can see this extra anatomical bypass that divides into two, and this is an axillo-bifemoral bypass graft. This is what you are seeing. Okay, and if I showed you the higher slices, you would see it originating from the axillary artery. So if you see anything like this, tunneled over the right lateral abdominal wall, this is an axillo-bifemoral bypass graft. As you correctly stated, it has the same contrast density as the aorta on the arterial phase. So this is going to be some arterially enhancing conduit or tube. And as we go down to the study, you can see this corrugations, and this is an axillo-bifemoral bypass graft. I guarantee you have not seen one before, which is fine. That's why you are here.
Thank you.
Next.
Thank you so much.
You're welcome. Next, please.
Next is Dr. Hina Farooq.
Okay. So this is slightly easier. Again, what is the study on this image?
So this is a CT scan abdomen, arterial phase.
Good.
At the level of kidneys.
Okay. Focus only on the artery. Okay, so I'm going to go, as we're going down, focus only on the artery. Okay, I'm going to go back up again. So focus only on the artery. So start here, down, 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 down. Okay, tell me about this image.
So there is dilatation of a branch of aorta at the level of kidney at its origin, and then in the lower sections, it is dividing into two vessels, right and left. And the left vessel, it shows a filling defect within its middle part. I would like to see.
You want what do you want to? You want me to go up? You want me to go down? Pick. What do you want me to go up or down?
Up.
Up.
Before
okay.
this level.
Going back up. Okay. So going down. What's happening here?
So dilatation. There's normal dilatation. Aorta is divided.
The aorta is divided. Okay.
A flap.
Okay.
There's an intimal flap. Whether it is. Fusiform dilatation of aorta.
Okay.
With
okay. Now, let me go back up again. So focus on the aorta. Now then, which one is the aorta, this or this? The native aorta.
So the lower one.
Okay, keep your eye on that and ignore the other finding. Keep looking at that. So remember what I told you, patent or not patent, occluded, stenosed, the aorta, here it bifurcates. Okay, so what are these then? This is what? This is the aorta that has divided, right?
Yes.
So what divided into what? What are these called? So this is what? These are what? The aorta divides into what two branches?
So common femoral, two common iliac branches.
Common iliac branches. Okay. So these are two common iliac branches, and you can say that they're heavily calcified. This one is occluded. So if these are common iliac branches, then what are these two things? Okay. What are these, right? So these are, you have identified these as the common iliac arteries. So what are these then? And now ignore, and now keep looking at them. You see, these. You know that the common iliac arteries are calcified. So what's going on here? So what are these? I'm going to keep going through this image, okay? All right, now I want you to focus on the right leg. Okay. Tell me about this on the right leg.
It is completely occluded. I cannot visualize it. Either it is...
What is occluded? What vessel are we at?
There is no visualization on the right side of the...
Of the what? The name of the artery.
So this is
you can see it here, right? You can see the artery here, right? So what is this? What is this artery called?
The
common femoral artery divides into what?
So profunda femoral and superficial femoral.
So which one is this one then?
So this is
I'll go up.
This is not deep.
This is not deep, so this is superficial, right?
Yes, sir.
This is the superficial femoral artery. Do you see it on this side? Do you see it on this side?
Yes, less opacified. Yes, sir.
Or not opacified. So what is this then? What's going on here? I don't see anything looking like this here. So what's this? Remember the last case. So what do you think is going on here?
So
I'm going to go down this. Yes. So this patient has, I'm going to go to the beginning again. So this patient has got two bypasses. So this is at the top. This is an aortobifemoral. So this is a graft from the aorta. This is an aortobifemoral bypass graft. Okay. And on the left side, it's anastomosed to the common femoral artery, and on the right side. But there's also an additional right fempop, femoropopliteal bypass graft, because you can see that the SFA, whilst diseased here, you don't see it at all here. And this vessel, there's no, anatomical correlation on the other side. So this is an extra anatomical bypass. This is a right fempop bypass. So this patient has got, and here's some images. You can see the graft here. So this graft has been plumbed. It's almost like a trouser graft attached to the anterior wall of the abdominal aorta. And then you can see a separate fempop. Can you see these lines again? So this corrugated. So this is a fempop bypass graft. And on the other side, the SFA, isn't great, and actually the SFA is patent, is occluded on this side, and it is supplied through some collateral. So what you see here is the SFA. You see no SFA over here, but this is the profunda, and the profunda is giving collaterals to the SFA. But on this side, you have a bypass graft. Clear? So now you've seen an aortobifemoral bypass. So if I go back through this, so if you follow the aorta up and down and you see it divided into these heavily calcified occluded vessels, then these tubes, right, this is something that man has implanted. So this is surgery. So this is an aortobifemoral bypass graft. And similar story, if you see something that does not fit any kind of human anatomy here, this is another bypass graft, and this is a FemPop bypass graft or femoral-popliteal bypass graft. But for the purposes of the exam, if you said this is a vascular bypass graft, that would be enough. Okay?
Yes, sir. Thank you, sir.
This is the X-ray chest of an adult patient showing ETT that is a bit lower than the its normal position. It should be high, and there is opacification of right-sided thoracic cavity involving predominantly the mid and lower zones with loss of cellhead with the heart and obscuration of the cardiophrenic and costophrenic angles. Fluid is also seen in the oblique fissure. I cannot see the vessels, hilar vessels as well. The heart size also appears to be enlarged on this image, and there appears to be obscuration of the right-sided hemidiaphragm as well. And I can also appreciate some opacity behind the upper aspect of the heart on this image as well. I cannot appreciate the comment on the ribs. I cannot see them well. Some chest leads are visible here. So this is opacified right hemithorax. So I'm thinking of some pleural effusion with some underlying consolidation, but the shape of opacity is more of centrally placed and convex.
Okay.
So it can be some hematoma or hemorrhage.
Do you want to ask me any questions?
Sir, I will like to I would like to take any history of any trauma of this patient.
Okay, so no history of trauma. Good question. No history of trauma.
Or sir, any previous comparison with the previous any previous imaging study?
Okay, all right. Okay, I'm going to give you something. I'm going to give you something because you asked me very nicely. But before I do that, is this patient well or unwell?
The patient is seems to be an ICU patient. Like he has leads.
Very unwell patient. Okay.
Yes,
good pick up on the endotracheal tube. I'm just going to diverge here for a bit. In one of the FRCR2B exams, and sometimes, you know, when you do this exam enough times, I haven't failed that many times, I walked in and I came across an examiner that everyone knows is there to fail people. I looked at his face, I knew who he was. I said, oh my God, not him again, not him. And he gave me a chest x-ray. It was actually a neonatal, babygram. And it had an endotracheal tube down the right main bronchus, and the left lung was still inflated. And the patient had rip-roaring signs of NEC. And that was his first film that he put up. And I've correctly identified the endotracheal tube was down the right main bronchus. I told him it needs to be pulled back. Then I talked about the findings of NEC. And then he said, okay, perforation, how would you confirm this? And then I said, we'll do a lateral decubitus view. We did the lateral decubitus view. And the first thing I said was the endotracheal tube has now been correctly sited. And I did that deliberately because I knew he put this film up not for NEC, but to pick up that endotracheal tube down the right main bronchus with a lung that's still not collapsed. Nasty. So I said to him, the endotracheal tube is now in the correct position. He said, yes, forget about that because, that was his film to fail somebody. So don't forget your lines and tubes whenever you look at a chest x-ray. Right. So you've asked for something. Here was something done a few years ago. Okay. So what study is this?
So these are the coronal MR images. These are T2 weighted images involving the lower chest and abdomen, showing a grossly showing the to me it appears to be a dilated, kinked and dilated aorta with the thoracic and descending aorta with the flow voids at the level of kink towards the right.
Okay. Okay, so based based on this person obviously had an MR for something completely different scout view. So this was picked up. This finding that we're going to go through and eventually come to a conclusion was picked up on the scout view of this MR. So then the chest X-ray. This is a chest X-ray done subsequently. Tell me about this chest X-ray.
So this chest X-ray shows the grossly widened mediastinum, and widened mediastinum and it is more on the right side as well as on the left superior mediastinum. I cannot appreciate the aortic contour. So the aortic contour is lost on the at the level of knuckle as well as.
Wait a minute. So what is this? What is this?
So this can be aortic aneurysm.
Okay. I'm going to give you, because you've done so well, here's a lateral chest X-ray. Or do you want me to go back to the AP? Do you want the lateral or do you want the AP?
I'm
no? Okay, here you are. You didn't like it, did you? Yeah, let's stick with the AP. Forget the lateral. So what is this then? So what's your diagnosis? So remember the first chest X-ray I showed you, patient very unwell. You told me about all of those findings. This was a few years earlier. Okay, so coming back to this, what's happened to this patient? What is the diagnosis?
Maybe this has ruptured now.
Ruptured what?
The aortic aneurysm has, this is periaortic hematoma or ruptured aneurysm.
Where? Of what?
Ascending aorta and arch of aorta.
Okay.
Stanford type
excellent.
A.
Yes.
Stanford type
well
A. Patient should be surgically needs an emergency management because coronary arteries and cardiac tamponade can occur as a result of this.
You see, this is the kind of answer that is music to the examiner's ears. You would get full marks for this case, especially with your management. Excellent. Okay, so this is the CT scan of this patient. You've done very well. So a 14-year-old female with chest pain. And again, focus only on the arteries. So I'm going down, 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 down.
Okay, so so can you please go up again?
Yeah, and if you know the answer, just say it.
So there is an intimal flap. There is an intimal flap in the arch of the aorta and descending aorta that is dividing the lumen into the two. So this is aortic dissection.
Okay.
Right.
Right.
Oh,
the arch of the aorta was not involved. I know I haven't shown you the arch of the arch of the aorta is not involved.
Okay.
So this starts pretty much here at this vessel. What artery is this?
Okay, this is left subclavian artery.
Left subclavian artery.
So this intimal flap is distal to it.
Okay. So which one is the false lumen? Is this the false lumen or is this the false lumen? The bigger one or the smaller one?
So the bigger one is the false lumen because it's forming beacon surrounding the smaller one.
So what is your answer? So what is this? So this is a what?
So this is a descending aortic dissection, Stanford type B, with no evidence of rupture.
Excellent. What's the management of these generally?
So it's treated conservatively. There is no surgical emergency in this unless it is ruptured.
Okay, or if the patient has, if there's a rupture, or if the patient has become hypotensive, or there is vessel compromise, because the false lumen, the false lumen impedes flow to the visceral vessel. So you can see there's a transplant kidney here that doesn't look very happy. It's not really enhancing very well.
Yes.
So you did well. This is a type B dissection. Now, quickly, a little bit about acute aortic syndromes. I think you get asked this in your exam. So these are the 3 acute aortic syndromes that I want you to focus on. And I've shown you pretty much all 3 of them. I've shown you an aortic dissection just now. You've got an aortic intramural hematoma I showed you earlier. and a penetrating atherosclerotic ulcer. And the fourth thing that you can add to this is a thoracic aneurysm. So aortic dissection, I found this picture off Twitter from one of my colleagues in London. So this is the problem with an aortic dissection. You see, you're trying to get into this can of Pringles, but for some reason, there's no way you're going to get to any of these tasty chips, you see, because you've got a dissection flap here and it's not going to go anywhere. And the more you tear into it, the less likely you're going to get any Pringles. So this is a good analogy of an aortic dissection. So it's an intimal tear, and it causes the flap being raised between the media and the intima. And what it does is it then compromises access of the vessels to blood flow of the aorta, because the blood is now going to track through this dissection. And the deeper you go down, the less likely you're going to end up crushing the Pringles, and they're just going to look like just like debris. So you're not going to enjoy your Pringles of an aortic dissection. Right. So again, the classification, is well known. Stanford type A is proximal to the origin of the left subclavian artery. The treatment of type A is usually surgery and surgery by the cardiac surgeons. Type B is then managed by vascular surgeons, either by conservative management or by a stent graft. So the true lumen is always smaller and compressed by the false lumen. And the false lumen is the largest lumen, and there are some signs to kind of look for. So type A dissection, obviously you can see that the true lumen is compromised by the false lumen. And it's important when you're looking through these studies is to follow the true lumen and false lumen and figure out which vessels come off which lumen. So the celiac, the SMA, which direction do they come off? Because the lumens kind of rotate as you go down the aorta, in contradistinction to an IMH, which remains constant, has a constant relationship to the aortic wall as you go down. So it's important that when you look at this, figure out which one is the fault. So number one, is it a dissection or not? Number two, is it a type A or type B? Number three, the extent of the dissection. Number four, which visceral vessels are perfused by the false and true lumen? And number five, what are the consequences of this? So obviously, if you have malperfusion, this will require intervention. So a type B dissection, the false lumen is larger than the true lumen, and you can have this beak sign where you can have some thrombus along the dissection flap, and this is typically seen in the false lumen. I can't remember why I was showing you this. Okay, yes, this is a type B dissection. And this is the aortogram before a stent graft is placed. And you can see here that this is the true lumen, a smaller true lumen and a larger false lumen. And obviously the extent of the flap is here, and a stent graft has been deployed, and you can no longer see the false lumen. So this is how these are treated endovascularly. IMH, I showed you a case of IMH earlier. Typically, if you see circumferential crescenteric high attenuation thickening on C- or on the non-contrast CT, this is pathognomonic of an IMH. What is IMH? It is hemorrhage localized to the aortic media, and it occurs from bleeding from the vasa vasorum. So when you come across this in exam, and the examiner hears circumferential crescenteric high attenuation thickening on C-, they know that you know that this is an IMH. So just say those key words so the examiner is picking it up. So some of you, actually many of you, as you were talking, you were using these key words, and I knew in my mind this person knows this stuff. And this is the way, the manner you need to conduct yourself in the exam is you need to be authoritative. They know that you know what you're talking about. So IMH does not enhance. So you can see here a non-contrast CT, hyperdense rim because there's hematoma, and it does not enhance on the contrast enhanced imaging. It maintains a constant circumferential relationship with the aortic wall. So if you see it here sort of anteriorly, as you go down, it will maintain this constant configuration. Type A, again, urgent surgery. Type B, clinical conservative management or endovascular treatment based on any complications as a result. Ditto for penetrating atherosclerotic ulcers. So penetrating atherosclerotic ulcers will occur in background of extensive atherosclerosis. The condition I showed you was not a PAU, it was an ulcer-like projection because there was very limited, there was actually no atherosclerosis in that aorta. Thoracic aortic aneurysm, we've already done extensively. And traumatic pseudoaneurysm, again, in the history of trauma, pseudoaneurysm, false aneurysm. Here is a 5-year-old child, motor vehicle accident. There is a pseudoaneurysm of the descending thoracic aorta, and this was treated with